For those of you that don't know me, my name is Willie Baker, and I'm going to be moderating this session. I'm going to ask that everybody hold their questions, at least verbalizing them, until the end. There'll be some time, but feel free to jot your questions or comments in the chat session. So again, I'm Willie Baker. I actually chair the ED Administration and Clinical Operations Committee, which sponsored this talk. And I think you're in for a treat. This is going to be a great didactic with some didactics at the beginning and a panel discussion towards the middle and some questions at the end. And we're going to chat about how to unclog your emergency department and how to customize a vertical flow model in the era of COVID. Now, this talk was accepted prior to COVID, and then the team modified it during this last year to account for some of the new challenges we have. So I'll let each of the panelists introduce themselves.
Thanks, Willie. My name is Keith Hemmerts. I'm the medical director at Hospital of the University of Pennsylvania. Excited to be here today.
Hi, everyone. My name is Hisham Valyudin. I'm a fellow in emergency medicine administration, operations, and leadership at the University of Pennsylvania.
Hi, I'm Ben Sun. I'm the chair of emergency medicine at the University of Pennsylvania.
Hi, welcome everybody. Tim Loftus, medical director at Northwestern Lake Forest Hospital.
Hi, everyone. I'm Sanjeev Malik. I'm the vice chair of operations for Northwestern Medicine.
Hi, everybody. I'm Mike Schmidt. I'm an associate chief medical officer at Northwestern Memorial and also the current medical staff president.
Great. None of the panelists today have any financial disclosures. And as Willie said at the beginning, this talk started out as a talk about vertical flow and how to implement it. But then in the era of COVID, it morphed a little bit into how to do that. And now with national volume recovery strong over the past few weeks, I think this is actually a great time for this topic, both for the volume recovery and for the COVID aspect. So I think I'm going to hand it over to Tim to start with some background and objectives for the talk.
Thanks, Keith, and welcome everybody. Just to walk you through our objectives, which are fivefold this afternoon. We're going to cover some basics of split flow. So to speak, we got to learn how to block and tackle before you can run and end around. We're going to walk through some particulars of our local experiences and learning opportunities that we're hopeful, can inform the broader discussion. And then we're going to think through some additional considerations of split flow implementation and optimization, and ultimately put this into the context of COVID specifically. But finally, and perhaps most importantly, we're going to leave plenty of time at the end for panel discussion and question and answer. So going to the next slide here, just, before we get into split flow specifically, a couple of, moments to discuss some basic terminology. When we think about split flow and the evolution into split flow, it's helpful to kind of think about some basic concepts of acuity segmentation. Traditionally the patient arrives, they get triaged, an acuity gets assigned, and then ultimately they're segmented by that acuity into your sort of traditional minor care, urgent care, geographic care locations versus sort of a main or high acuity location. And if we take that process one step further, how can we ultimately expedite that care delivery at the front end? Well, you can put a fast track area up front and kind of pick off the super low acuity, traditionally called a super track model, super track. You can empower the nursing staff to triage and initiate care accordingly. You can protocolize the front end care with nurse-driven order sets. And then ultimately you can put a clinician up front to initiate care immediately after triage. And taking that even further, how can we not only expedite that front end care, which is often sort of a front end diagnostic initiation, but also in conjunction with treatment and discharge? Well, you can put a clinician or physician in intake, particularly for those locations that don't, where advanced practice providers don't operate independently. And this often removes the sort of traditional triage process, or you can even put a team-based triage method or rapid medical evaluation zone up there. But the bottom line is that many of these concepts and processes sort of happen in combination with one another or simultaneous to one another. And so there's room for significant heterogeneity based on ultimately your department's needs and resources. And then, thinking about split flow specifically, if you go to the next slide, and kind of why we talk about split flow. First of all, it starts with queuing theory and the theory or concept of constraints. And now this is not an entire discussion about queuing theory, but just to sort of introduce some broad concepts, it's the realization that we have unscheduled, but not necessarily unpredictable demand or patient arrivals to the emergency department. And the variability of that arrival time can lead to both queues, which we're trying to fight against, but also unused capacity to a certain extent. And a major goal of split flow is to proactively remove those constraints and manage that utilization to keep it, about 80 to 85%. So to speak. And split flow is able to do that. Split flow, if done well, if enacted well, can provide the right care. And by that, I mean matching the resources to the needs of the patients across multiple domains. And by expanding flows, by expanding capacity, one is able to deploy multiple servers, utilizing parallel processes, taking advantage of parallel processes, which can expand your capacity and can accelerate care delivery across all acuities, not just low acuity, but all acuities and resource needs. And how do we do this? If you advance to the next slide, how do we enact split flow, right? I already sort of introduced a couple of those concepts, but ultimately we split patients into multiple flows or multiple pathways based on the resources that they may need. And often those resource needs are identified using sort of traditional ESI or emergency severity index or acuity designations. And we split them as early as we can, often with a pivot provider or clinical greeter that's in the waiting room, and keep those patients moving as quickly as possible, keep a constant forward flow, constant vertical flow, as the saying goes, keep vertical patients vertical and keep them moving forward. All the while removing waste, right? Trying to remove non-value added steps throughout the process. An example would be removing traditional triage process or sort of your traditional triage location, and then enacting some component of parallel processing. We call it the golden moment here at Northwestern. You can conceptualize that as sort of the pit crew model, right? Where multiple servers, multiple resources care for the patient in sort of a parallel or simultaneous fashion. And if you go to the next slide, this is in particular a burning platform, so to speak, for the academic environment. Most, if not all of academic EDs, unfortunately, are realizing rising volumes, rising EMS utilization, acuity, and care complexity as well. And this is ultimately, impacted by the proximity of urgent care centers or immediate care centers, which are able to deliver care to the super low acuity. And this leads to what we all know, right? Remarkably high inpatient occupancy and inpatient capacity, which leads to inpatient boarding in the ED and crowding within the ED. And this, our patients feel as long waits, right? And in particular, a theme that's going to come up this afternoon is long waits for the low to moderate acuity population. But within that moderate acuity population, there's room to sort of conceptually think about this high variability ESI 3 or moderate acuity population, what some term the sneaky sick population, and how to provide best care for that patient population. And ultimately, split flow can target many of these issues, right? By expanding virtual capacity and segmenting flow to reduce times, to reduce queuing. And it's our hope that upon reflecting upon experiences from our two institutions that we can kind of better inform the discussion. So with that, I'll sort of turn it back over to Keith to talk about Penn.
Great, thanks, Tim. I think I'm actually going to immediately pass it over to Dr. Sun to talk about, for the Penn experience, what was our burning platform and what was the motivation to undertake this massive change?
Hi, so I started as chair here at Penn in September of 2018. And this slide illustrates the burning platform as I saw it, where there were significant opportunities for improvement at our primary hospital, the hospital of the University of Pennsylvania, otherwise known as HUP. You can see these numbers, which were quite concerning to me Our overall left without being seen rate was nearly 10%. Our door to doctor median time was 80 minutes. Our length of stay for discharged patients was 5 hours. And what was particularly of concern to me was, in contrast to national and North American data, which suggested that many patients who left without being seen were low acuity, this was certainly not the case at HUP. 20% of our total walkaways were ESI2. And when we dug down deeper into these data, these were patients who were transplant patients. These were patients with LVADs. These were patients who were on active chemotherapy. And so to me, this was a burning platform. We had to fix this. For quality, safety, patient experience, medical, legal, and financial reasons. So you're going to hear from Keith our technical approach for how we decided to address this challenge.
Great, thank you, Ben. Our center, like many other academic medical centers, we discharge the vast majority of the patients we see. We've got this 70-30 split, which is probably within a few percentage points of what each of your own shops are. And so recognizing that of those discharged patients, about 35% of our ESI2s get discharged and about 80% of our ESI3s get discharged. So that population, that ESI3 and less sick ESI2 population, is the population that gets discharged, and it's the population where there's opportunity. The year that we decided to tackle this, we also made sure that our efforts were in close alignment with what was important to the folks in the C-suite. And I think that we'll talk a little bit later more about change management, but making sure that the efforts that you're undertaking in the emergency department are closely aligned with what the C-suite is really got on their radar for any given year is really crucial for success. So the way that we thought we could move the needle on this was by integrating vertical flow. And I think the folks from Northwestern are going to talk a little bit about aligning process and space. And we'll talk more about that later, but I do want to say that was part of our thinking as well, knowing that we had a new hospital tower going up, and in our new emergency department, which we're moving into in about 6 months, there was a space specifically carved out to do vertical flow, and yet it was a process that at Penn we had never done before. So we recognized this as an opportunity to pilot workflows and really become experts in these workflows before we moved into a space specifically dedicated for it, and also to take advantage of the ability to tweak that space for the workflows that were worked well for us. So, the situation at Penn involved a massive change management program. It wasn't something that we were iterating on previous versions of vertical flow. It was a massive change for anything that we had done previously. And in such a change program, I think having really clear, explicit goals that are ambitious yet achievable is really important. So we set very clear goals for our left without being seen rates to be under 3% overall and to be 0% for our ESI2 population, for our door-to-doctor times to be under 30 minutes, to carve an hour off of our median length of stay for discharged patients. And we thought that by achieving these three things, we would be able to improve our patient sat up to the 50th percentile. But again, zooming out, setting those very clear, very explicit goals, it really gives you something to focus on. As I said, for us, this was a huge change package. It wasn't just tweaking a little bit of flow. It was completely re-engineering flow through the entire department, from our front-end intake processes, optimizing a fast track for our lowest acuity, implementing a vertical care mid-track, which we call forward flow for that vertical population, new nursing roles, completely new staff allocation, and new schedules. So again, for us, this was the first step, and it was a big, big change process to ultimately get the right people in the right space, using the right processes with the right technology to support it. So I'll spend a minute on this slide to talk about what our actual flow is. So when our patients arrive in the emergency department, at the very top, you see that the sickest of the sick will go right back to the resuscitation bay or otherwise an open bed in the acute care area. And then if we jump down to the bottom, we'll see that the least sick just go directly to our fast track area. So they'll get a quick traditional nurse triage and then move to a fast track area where they can be expeditiously seen and discharged. But both of those populations are the minority of our patients. The vast majority is ESI2s and 3s. And so all of those ESI2s and 3s will come through our physician and triage. And we did decide to go with a physician and triage model believing that keeping our door-to-doctor times under 30 minutes would be a big driver of dropping our left without being seen rates. And that position in triage has kind of a triple role. The first is to keep things moving and make sure that our door-to-doctor times are under 30 minutes. The second is to make the queuing decision. Is this patient going to be vertical, in which case they can go to our forward flow area, our vertical track, or are they going to be horizontal, and do they need a bed in the acute care section? And then the last thing is putting in orders on these patients. So it's primarily diagnostics, primarily laboratory orders and radiology studies, occasionally some medication orders, whether it's oral analgesics, things of that nature. Although we did have some kind of unanticipated and pleasant surprises, like our compliance with our sepsis metrics improved because we could get antibiotics to neutropenic patients much earlier. So we found this model to be particularly effective for keeping that door-to-doctor time under 30 minutes, and then saw a tremendous correlation with our left without being seen rate dropping as well. I'm going to go back to Ben for a little bit more on the change management process.
Yeah, so change management was huge. I mean, the technical redesign was, I would say, half of the effort. The other half of the effort was to make this change stick. And when you look at the change management literature, something like 80% of change efforts will fail. And because this was such a high stakes effort for us, failure was not an option. So we used a evidence-based approach to maximize our chance of success. You can see at the very bottom, there's four elements that I thought were particularly important. I would say the most important one was leadership. So making clear that this was going to be the top department priority for the year. This is not something that I delegated. This is something that I took on directly and led from the front. Governance was really important. We created a new operational leadership structure, which was a combined integrated team of physicians, nurses, APPs, and the other important ancillary members of our team. We met very frequently, so during this change process, we met up to 3 times per week. During the maintenance phase, we're meeting on a weekly basis. Getting good data to know that you are going in the right direction. So valid data that is timely was also very important. So we spent an enormous amount of time creating key performance indicators that were automated that would provide us with near real-time information that we could trust. And then reporting that back to all the providers. So on every day, we report the key performance indicators from the most recent data, which is 2 days prior. We did that to hold ourselves accountable to the goals that we had set. And so if it looked like we were achieving those metrics, then that would be a great story to tell. And if we were not achieving those metrics, it meant that our team needed to think about what we needed to do differently.
Yeah, and it's a little bit of an approach of kind of radical transparency, where our daily key performance indicators go out to the entire department, and they are not de-identified, so everyone can see, how productive each of the providers were in the different areas. And the back end of that, I think, is as time goes on, the natural tendency is for backslide, and so keeping a really close eye on this for the purpose of process control, months and frankly even years after the initial change is, I think, really, really important. So I'll briefly talk about our results from this first year that we did this. As you can see, we were able to drop our walkaway rate pretty substantially down to 2.5%. And our ESI2 walkaway rate, we dropped down to 0.4%. The door-to-doctor time was 26 minutes, and the discharge length of stay went down to 227 minutes. So tremendous improvements from, again, what was a massive change package. And the purpose of this talk today is not to talk about money, but there are financial implications to this as well, right? Every patient that leaves without being seen is essentially revenue that is being left on the table. So for the previous year, for fiscal year 19, if we had had comparable left without being seen rates, it would have been an additional almost $350,000 in professional fees, which is not an insubstantial sum of money. Our patients' experience data improved a little bit. As you can see, we had modest improvements in these 3 areas. I think everyone knows that moving the needle on patient experience at an academic medical center is a really challenging thing to do. But this kind of supports my personal thesis that what patients really want is to get into the emergency department, get treated, and then get the heck out. And so I think that this supports that a little bit. And now I'm going to turn it over to Dr. Valyudin to talk about our challenges and adaptations during COVID.
Thank you. So the split flow was an integral part of our COVID response over the last year, especially given that when initially the pandemic had started, there were a couple different buckets and types of patients that would come into the emergency department. Either they were in extremis, coming in pretty hypoxic, requiring immediate intubation, or they were undifferentiated, having some upper respiratory symptoms or atypical symptoms, or they were in the third bucket, which is they were asymptomatic, they were really concerned, they had questions, there were possible exposures, and so they would come to the emergency department for care. And so using the split flow model, we were able to use early segmentation based off of patients' age, their comorbidities, exposures, and vital signs, including their pulse ox, to make decisions on whether we can get them in the vertical flow model or the horizontal flow model. And the main premise for this was, given how communicable and given how undifferentiated these patients were, we wanted to get them out of the emergency department waiting room and get them out of the emergency department as fast as possible. It was the safest thing for the patients and also for the staff, considering that the longer they would sit in the waiting room or the longer time they spent in the emergency department, they could spread the illness across not even just patients, but also for staff. So in order to do this, we used an interdisciplinary team that was able to, in conjunction with the local infection control guidance, able to develop plans that we were able to see these patients and get them out of the emergency department within minutes. Next slide, please. Two of the programs that enabled us to do this was one called COVID Watch and another called COVID Pulse that we developed. COVID Watch was a robust system to get patients the results of their tests after discharge, and also served to for symptom check-ins and escalation protocols. Namely, the patient would get swabbed in the emergency department and they would get discharged immediately. And the COVID Watch program would be the one who would get back to the patient, text them, let them know if they had a positive result, negative result, and what to do next. And the COVID Pulse program was an add-on to that, which would provide the patients with a pulse oximeter and have symptom management control to ask them if they were getting worse to come back into the emergency department for further reassessment. Next slide, please. These are just two screenshots of the wireframing of how the process looked like. On the right is the patient flow diagram of what the workflow looked like. And on the left is a screenshot from a cell phone of what type of messages that they received. Next, I'd like to hand it off to Dr. Loftus to talk about the Northwestern experience.
Thank you much. I appreciate that. So now to kind of compare and contrast a little bit the Penn experience and that of Northwestern's. If you can go to the next slide. This was our challenge, right? This was, data from fiscal year 2015, but this represents our burning platform, similar to what Dr. Sun talked about at Penn. We didn't quite hit our mark with respect to lengths of stay, patient experience, and certainly our walkout rates. And at Northwestern, it seemed to be driven with some common features, right? High inpatient boarding, rising patient complexity, but also we did have a pretty significant population of particularly moderate acuity or ESI3 patient populations that had really lengthy waits. And if you go to the next slide here, to a certain extent, I want to start at the end, right? To illustrate our experience, we thought we'd start with the process. And one of the main takeaways, not necessarily the details of the slide, but one of the main takeaways is that after we transition from that sort of traditional post-triage, minor care, sort of geographic care location, we iterated and evolved our process first, our operations first, and then after a lengthy time proving that concept, we were able to design the space to match to our operations. And if you go to the next slide, this is an illustration of our CAT flow or what we call our care arrival tract. And it's built around the concept of constant motion and constant forward motion. But we got to this process, again, like I mentioned, through an iterative evolutionary timeline. And, I wanted to turn it over to Sanjeev to kind of walk us through that evolution to get some better understanding.
Thanks, Tim. So the evolution of Northwestern Schwartz split flow was really predicated on understanding that patient flow model. And we spent quite a bit of time really defining what that forward flow that we wanted to be was. And a lot of that's predicated on the problem that you're trying to solve to, right? So as we looked at our institution, our setting, and knowing that each ED's problems might be slightly unique, our challenge in our institution was that we were seeing a drop in low acuity volume. So we had a very high functioning fast track historically, and as volumes of ESI 4 or 5 patients were dropping and being absorbed by immediate cares, they were being replaced by much more complex patients being referred for diagnostic testing. So these patients were taking up more time in the emergency department, taking up more space in traditional horizontal rooms. And so what we felt was we really needed to accelerate that so that we could get to that middle acuity population that was suffering long wait times. So we did various iterations of provider and triage with some levels of success, improving door-to-doctor times, being able to initiate care, but we still weren't quite solving the problem that we were set out to do. So in 2015, we made the commitment to transition to a true split flow model of care. And with that, we really didn't have the ideal space for that. But as Tim mentioned, it was actually quite important to us to do some trials and errors and implement the process so that we could get buy-in from our executive team and build out the space that would match our operations. So in 2018, we were able to finally do that and build out our full-fledged area that matched our operations. And what we saw was quite a bit of a bump in utilization, which was great. And the ability to get patient or providers to use the space, there was much more buy-in because they had used, frankly, a less desirable model previously to that. But even within our 2018 version of what we call care at arrival, we still wanted to push the envelope. We needed from our analytics about 40+% of our patients to go through that area, and we weren't quite there. And then in 2020, of course, COVID hit and threw a wrench in everything, in that we really had to take a step back and think about what does vertical care spaces mean for these COVID rule-out patients? What are the infection prevention concerns? What can we do with those? So we'll talk a little bit about that in a moment. Next slide, please. So I'm going to take you back to 2015, and this is our initial iteration of our split flow model. So this is a floor diagram of our pre-existing triage space. And what we did was we retrofitted this into a simultaneous provider and nurse evaluation zone. And what we did, and it's not on the screen here, but we had a pivot provider at the front that really used that screening tool where we split the flow under 60 seconds, all visual. So we did not use ESI. It was all about patient complexity, the chief complaint, and whether the patient was ambulatory. And if they met those criteria, they could come into this space. We did what we call the golden moment. We had our physicians and nurses try to simultaneously evaluate the patient, determine a plan of care, and then move the patient forward. If it was determined the patient was not going to be able to lie flat or remain vertical, then we needed to move them out to a main area. But if you can click on the next animation here, this is somewhat a picture of our evaluation zone. So we were able to see these patients, in small care spaces, but we used certain recliners such that we were able to provide the examination that we needed to determine the plan of care. We also had separate rooms where if we needed to take the patient for a pelvic exam or procedure, we were able to do so and still take care of them in that zone. Next slide, please. And then all patients moved to a results waiting area. Now, again, as I mentioned, we did not have the physical design built out at this time. And so we needed to retrofit. And what we did was we took away space from our existing fast track that was no longer seeing as many patients and essentially took a bed out and put recliners in there and made a makeshift results waiting area. And as you can see, it's quite cramped. This is a 100 square foot space with up to 5 patients plus minus a visitor. So it created some challenges in the sense of patient privacy, and now in the current era of COVID, you worry about infection prevention concerns. But from a forward flow and operations perspective, it actually had the desired effect. We were able to get patients out of rooms into a results waiting and then move on to the next patient for evaluation. What it did show, though, is that we had some challenges that we knew we wanted to solve to when we built out our space. We knew that reassessment was a challenge. We were bringing patients out of this room into another private space to go over results discussions. We knew that reassessments by nurses for vitals weren't as private as we wanted. So these were things that we wanted to solve to in our final iteration of our space. So next slide, please. So I'm going to turn it back over to Tim, who can take you through some of our lessons learned and what our current design looks like and how it flows with some of our numbers. Thanks.
Yeah, thanks, Sanjeev. So this is just an illustration of now, the model that is current, right? And if we look at the diagram here, the patients walk in and they're immediately split into those two care pathways or flow models. And the design of this space was very much built intentionally to move it closer to the patient as much as possible and to encourage that forward flow. You see if they, if they're split down into the lower portion here, our care to arrival track, they get immediately placed into an evaluation or treatment space. And then if deemed to be appropriate to pull to that results waiting pod, they would then move forward in their flow and continue to care for there. And if you fast forward to the next slide here, this is a depiction of, the concept of that pod, the concept of that results waiting space as we were designing it. And we designed these with our operations in mind. This is a traditional ED treatment space is about 12 by 12 or 144 square feet. This is essentially 6 by 6 or a quarter of that space. So something to keep in mind. And if you go to the next slide here, this is just another depiction of that results waiting space, which, again, was built to the need, built to the operations. And so it has telemetry monitoring capabilities. The recliners are able to go fully supine. There's an IV pole within that space. There's separate workstations and barcode scanners for the purposes of reassessment and ongoing treatment and management of that patient, rather than that sort of backward flow, which can happen. And you can just see those side by side there. And so that's where we are now, right? We have the fortune of utilizing these spaces to add capacity without adding much in terms of our expanding, our footprint, and really able to drive the optimization of that flow within the space that we have. And if you're able to go to the next slide here. And again, to reiterate, the versatility of the vertical space is really something that is kind of a huge aspect of our flow model at Northwestern. And again, to reiterate what I mentioned, we built this space, we designed this space for the need that we had. And that need was to be able to care for patients who weren't just super low acuity, but were moderate and to a certain extent, high resource needs in that area, but safely able to be cared for in that area. And if you can go to the next slide, this really was fortunate when we reflect on how we utilized our split flow model within COVID as well, because a year plus ago, 14, 15 months ago, initially, we cohorted the patients with suspected COVID. We segmented them by acuity, as Hisham mentioned, and we didn't utilize our split flow model. If they were low to moderate acuity, they went to an additional care space, similar to what has happened at many EDs across the country, an external care environment, an ambulance bay, to be evaluated. And then the critically ill still were placed in the main ED in available negative airflow rooms as capacity allowed. But now, fortunately, with the availability and the implementation of rapid testing, with a more nuanced and evidence-based approach to the understanding of risk and safety concerns, particularly as we think about aerosolization, we were able to optimize bed turnaround as an example, EVS cleaning and turnaround of treatment spaces, as well as with an understanding of the benefit of universal precautions. We were able to implement care of the suspected COVID patient in our split flow model. And we were able to capitalize on those previously redesigned pods, which were 6 by 6. And fortunately, we're able to provide us with a measure of social distancing from a safety concern, but also privacy as well. And to kind of summarize this, I wanted to send it over to Mike Schmidt, who can kind of help us reflect upon what we've learned.
Thanks, Tim. Yeah, I'm just going to take a couple minutes to briefly talk about some of the lessons we learned on this journey. So the first thing, the first point I'll make is that really that change is inevitable. And, in order to meet the challenges that were before us, we really needed to continuously improve. And so the other thing I'll say about that is that there's really no one size fits all for this process. You really have to identify the challenges before you, the issues that you're trying to solve to. And from that, build your proof of concept and targeted solutions around that. You can see from our discussion and the points that Sanjeev went through with our evolution, we went through many iterations before we really got to a point that we think is kind of what we want and what we need for our patients. Not just, I think the second point is also a really big one. And really that's that the space should really be designed around the operations and not the other way around. So I've been around long enough that I've been through multiple constructions, multiple renovations, and I've seen many happen where there really probably wasn't enough focus on what the patients needed and what the caregivers needed in order to take care of their patients optimally. So really, when you're going through this process, really think through your operations, implement your operations, build it, and then think about how your space is going to help with your operations and processes. Another point around the space is that really the space should be as flexible as possible. If you're too specialized with the space, it's going to be underutilized and it's just not going to be efficient enough. So even though, of course, we want to put a lot of emphasis on disaster management and infection control, as we've learned this past year, you also want to make sure that the space is flexible enough so that you can use it efficiently. Along with the space, the other resources should really match the patient and really probably have less focus on the acuity category of the patient. So your personnel, your equipment, your space, all really should match what the patients are needing. So, one example is that we're putting most of our chest pain patients actually through this vertical space now. And although they're a higher acuity, the resources match them. Of course, if they're really high acuity or if they're very complex, the resources in the vertical area might not be matching them. But for the vast majority of patients, it's a fairly straightforward complaint, and they're ambulatory, and we kind of know what we need to do with them, and they fit well in this vertical operations. And then lastly, not least, is the culture change. And we've kind of talked about that a little bit earlier, but you need executive buy-in, you need buy-in from the staff. And oftentimes, if people see that what you're doing is best for the patients, and ultimately it's usually best for themselves, they'll usually follow along with your lead. So with that, I'm going to turn it back over to Keith.
Great, thanks, Mike. I don't know that I can summarize any more eloquently than what Mike just did, but segmenting the flow early is really, really important. And it's okay if it's imperfect segmentation, but by segmenting into 2 or 3 care tracks, you're essentially creating multiple multi-server queues, which is a far more efficient model than a single server type queue. So even if that initial segmentation or queuing decision is wrong, it's better to be wrong 5% of the time and still segment than to just not do it at all. I think Mike and Tim talked a lot about keeping vertical patients upright, keeping them moving forward. For us, this was a big culture change, recognizing that not all patients need beds, that an exam room should be treated like a tool. It's like your stethoscope. You use it when you need to, and when you don't need a patient in a room, you got to get them out of the room. And that's how you can use your space more efficiently. And then, you got to take stock of your own shop and say, what is this going to be for us? Is this a massive culture change, a massive change management process, or do we already have a culture of continuous improvement, continuous innovation, and we just need to continue tweaking what those processes are? So I think those are some kind of high-level take-homes, and I think there's some questions in the chat, and I think that's where we're at next. So Willie, maybe I can ask you to moderate the chat.
Sure, Keith. I mean, this was an awesome talk. I really enjoyed it. So let's come back up in here. Does your physician in triage do any documentation on the patients they see and send them to an acute area or forward flow. So maybe you can talk a little bit about documentation as well as the culture that that existed before and after implementations in your shops with respect to patient ownerships.
Yeah, I'll say for us at Penn, our provider triage writes an extremely abbreviated note that can be completed in about 25 or 30 seconds at the most. I mean, it's really just a couple of words about the chief complaint, a couple of pertinent words about the exam, and a quick drop-down list about the plan. So it's not even free texting a plan, it's just pre-populated options about IV placement and imaging studies and so forth. And that went through a couple of rounds of iteration, got reviewed by our Office of General Counsel to make sure we were hitting that right balance of liability, but being informative. And part of that is also, does that qualify as your medical screening exam? So we do a little bit of documentation, but not a lot. And that was, for us, again, that was a big culture change, recognizing that you're not owning the patient for the duration of their visit, that you're taking your best guess at what's going to happen to them and what they're going to require. But that was a huge culture change for most of our faculty, that you're not going to be the patient's doctor, you're just seeing them for less than 5 minutes in triage.
And on the second part of that question, Keith, can you comment a little bit about the culture of patient ownership prior to and after your intervention? Because we're pretty much own our patients in a pod. We sign them out. We like to have a plan. This is a shared responsibility, right?
Yeah, I'll speak a little bit about that, and I wonder if maybe Ben wants to weigh in on that as well. But we had a really strong culture of ownership of the patient in front of you, and zero sense of ownership of the waiting room. And so for us, it was shifting that perspective of your job is not when you've got a panel of 20 patients in the acute care section, but if you're on duty as a faculty member in the emergency department, your job is the whole department. And that means keeping an eye on the waiting room and feeling some sense of responsibility and ownership over every patient that's come to Penn seeking emergency care. And in order to execute on that ideal, it involves having somebody in triage. So kind of extending that notion of ownership from the 15 or 20 patients in front of you to every patient that's in the emergency department, and you have a vested interest in that. Ultimately, it was important to communicate that shared vision to the faculty and say, look, this is what we think this means. And 99% of people can understand that, and there's probably a few people who have a little bit of difficulty with that. But at the end of the day, it's not a difficult concept, and it's why most of us got into this field, right, to take care of sick patients. It's just reframing who those sick patients are. I don't know, Ben, do you have other comments on that? That was definitely a challenge for us here.
Yeah, no, Keith, you put it very, very nicely. It was a major paradigm change. I think we went through all the stages of Kubler-Ross to go from where we were before to where we are now. So it's definitely not for the faint of heart, but these sort of change management, the scope of the kind of change management that we went through did require a major break from what we were doing before and the conceptual models that we were using from before.
There was another question that Tim answered in the chat. It had to do with admission rates. I don't know if you guys want to comment from your shop, Keith.
Yeah, I'll give our numbers in a second, but I think Mike wanted to weigh in on that culture change point.
Yeah, I was just going to add, I think for the audience, it is a real barrier, though. I don't want to, downplay it. We went, that was sort of one of our iterations that we had kind of early on. And I think right now, the way we're doing it is probably a little different than Penn is doing it. And like I kind of mentioned before, I think it depends on, your own institution and what your needs are and how you want to implement it. The concept of seeing a patient, sort of getting stuff just started and then kind of handing them forward is a difficult concept for people to embrace. And I think ultimately what we landed on was that it really does take a team, and really because of the complexity of the patients we were seeing, it just made more sense for us to really sort of keep and manage those patients. And so that sort of turned into this, first being sort of that provider in triage, kind of seeing patients, seeing low acuity patients discharging or seeing higher acuity patients and get them started, it really turned into this team and this sort of split flow model where we have this care at arrival track and just trying to build as much virtual capacity, or in our case now, small space capacity with the pods in order to get to the patients most quickly and sort of bypass the traditional triage. So again, it's a little bit different models, but again, I just do want to say that it is a real issue to try to, do that sort of, quickly seeing a person and then handing them off. And I think it just depends on, how you want to approach it and, what you think is best for your institution. There was a comment about documentation that I think Keith had mentioned. We kind of, when we were in that model, we were doing something very similar. We just had sort of an open free text note that we would just document a couple of lines on, and then the full note would come on the back end.
I just want to add one quick thing to that, which is I think in the academic institutions, we also have to be, we had a lot of concerns from the residency as far as how does that care initiation impact the resident learner's ability to kind of make decisions. And so I think that there's no right answer there. I think it's something you have to navigate together. But another reason that in our institution, we kind of went more towards keeping the patients that were there and then just trying to increase the number of complexity of patients going into our split flow track, adding in chest pains, adding in pretty much anyone who could walk, we wanted going into that split flow track. And then that way there was enough business for the docs and the APPs who were working it to work through it.
So I think that answers to some extent Scott's question in the chat. There's a question about boarding, which I'll get to, and I'll just say that I have so many more questions about the financial side of it, how which we can't get into here, I think, with the time constraints. And I understand the $276,000 gain from your 2019 left without being seen. But trying to reconcile that with RVUs for individual physicians, justify that with the practice group, it probably costs more to staff that. So questions about how many hours a day is it staffed is I'll get to next. And in tying that on, did you decide that based on census or arrivals?
Yeah, Willie, there's a lot to unpack here in our remaining few minutes. I'm going to kind of rapid fire answer some of, I think it's Dave Portelli's questions. So our admit rates from our vertical care area is somewhere between 10 and 15%, and our admit rate from our acute care area is anywhere from 60 to 80%. So it's a pretty stark difference. Our staffing in our vertical care zone is primarily APPs with some attending oversight, and we're just starting to integrate residents into that area as well. Right now, we've got coverage from 7 a.m. to 2 a.m. in our vertical care area, and we keep trying to spread that out further and further. And the staffing for our care and our provider and triage is driven primarily off of arrivals. And I do think if you're going to have provider and triage, it should be based more off of arrivals. I think we talked about the resident education thing a little bit, and Megan asked a great question about boarding impacting forward flow. If your forward flow area, your vertical care area gets bogged down with boarders, that's the death knell right there, because those patients they don't get out of the beds and things just grind to a halt. So we make every effort possible to keep those patients, if they need to be horizontal, they have to leave the vertical area and go to the horizontal area. And that means one of two things. You've got a lot of boarders in your main ED and your acute care section, or you keep some of your boarders vertical, which sounds crazy, but we do that with a fair number of our patients who are just waiting for a bed upstairs. But if they're getting admitted for their, they're ruled out with 2 negative troponins and they're going to get a stress test tomorrow, no reason that patient can't wait for their OBS unit bed in a vertical fashion. So that's how we handle those things.
Yeah, I was just going to add on to that as well. It's not uncommon for us to have boarders in our pods, overnight. The appendicitis, the chest pains, a lot of those patients don't necessarily need to be supine. And so with boarding, that ends up happening not infrequently.
Well, we are at the end of the time here, and gosh, I think there's so many more questions to answer. I wish we had more time to have a discussion. I really thank you guys for this tremendous presentation and all of the Q&A period time as well. And I will be bothering you, Keith and Tim, more as we work on our front end operations in a very, very, very tight ED, big ED attached to a small, big volume ED with very few beds attached to a relatively small hospital. And I know Ben would have liked to be here, Ben White, but he's working a shift right now, so I'll be bothering him too. So thank you again to all of you as well as everybody that attended.
Thank you, everybody.